Okay, so we're going to start with this 8th seminar. For you to have the other seminars, you can ask for Sebastian, all the notes, and I also bring the note for this class, okay? So the topic of this class is about Corioamnionitis and ruptures of membrane, and we are going to figure it out if it is important to know about these topics, okay? I am Wenceslao Zegers, I am a Chilean doctor, and with Sebastian we are preparing these seminars for have a certificate at the last of the course, okay? This presentation also was supported by Dr. Ali Low. You know him? He's a medical officer. So the main goal of this class is going to be to know and use the correct terminology about these two topics. Have you heard about PROM or PPROM? Yes? So there are a few differences that can change all the management and everything. Okay, and also to recognize the two clinical presentation and to manage them adequately. Okay, so we are going to see about ruptures of membranes, the definition, the pathogenesis, the risk factors, the clinical finding, the diagnosis and the management, and also the same with Corioamnionitis. Okay, this is the root of this class. So why we are going to talk about this topic? Why we put it in the schedule of these classes? It is because many reasons. The first reason is that PPROM, that we will see the definition a few minutes after, is the responsible of 1/3 of the preterm birth. Okay? So that means that the main cause of perinatal mortality is caused by PPROM. Okay? Also, what about the incidence? The PPROM is about around 3% of the pregnancies, and Corioamnionitis is also around 3%, from 1 to 4 of all the pregnancies. So what does it mean? That if you work here in the Bagadi hospital, and in average per day you see a 30 pregnant women, more than 30, 50 pregnant women, and you attend 30 deliveries daily, you will see many cases of PPROM, of ruptures of membranes, and Corioamnionitis. Also, why is important this topic? This topic, the management, the treatment, and is very controversial in all the academies. Okay, so when is the exactly moment that we have to intervene to delivery or to give corticoids or to give tocolysis, prophylactic versus treatment antibiotics, etc. Those are questions that we want to resolve them here. Okay, and it's also important because this is mortality causes. Here we have BBC News, for example, maternal death by severe sepsis. Also, we have neonatal deaths in Prince Charles Hospital. I don't know where is it, but BBC News. So it's common, okay, and it's very preventable, the treatment and the management. Okay, so we're going to start about the definition. Ruptures of membranes. The name is very easy to understand what it is, but what it is pre-labor ruptures of membranes. So it's the ruptures or abbreviated as PROM, okay? It's the membrane ruptures before the onset of the labor, before the onset of the contractions and the cervical effacement and dilation, okay? Before was known as premature ruptures of membranes, but premature is a term that makes you confused because it's the same as preterm. So that's why it changed into pre-labor ruptures of membranes. And then preterm pre-labor ruptures of membranes. That is the same that PPROM. PPROM is the pre-labor ruptures of membranes, but before 37 weeks of pregnancy. And inside preterm pre-labor ruptures of membranes, or PPROM, and we are going to talk about PPROM to make it easy. There are many situations that we have to recognize and we have to treat like different depending in the gestational age, because you think that it is the same to have a PPROM on 24th week of pregnancy than to have a PPROM on 35 weeks of pregnancy. So it is different between depending in the gestational age. Okay. Well, there are many schemas, diagrams, or theories about the pathogenesis of PPROM. So my idea is not for you to know it and to learn exactly all the mechanism look another two, because it is also, we have to know that it's not completely understood, the pathogenesis, okay? But here I try to make a little summary, okay? First, we have to know that the strength and integrity of the membranes are given by some proteins, for example, collagens, fibronectin, and laminin, okay? But there are some proteases that make proteolysis, yes, that are called matrix metalloproteases, that are abbreviated like MMPs, okay? So these metalloproteases degrade these proteins, collagens, fibronectin, so decrease the strength of the membranes, okay? But the other side, there are tissue inhibitors of MMPs that inhibit these metalloproteases, so maintain the integrity and the strength of the membranes. It's a little confused, so but do you understand? Perfect. So there are some situations that make a disbalance and increase the amount of MMP. Like bleeding, we will see that one risk factor is abruptio placenta. Okay, mechanical stress. That's why we don't recommend to the pregnant woman to run marathon or make a strong exercise. Okay, inflammation. We will see that the tobacco produces inflammation, and subclinical infection, and also clinical infection. All the kinds of infection produce inflammation and produce also ruptures of membrane. Okay, so which are the risk factors of the Corioamnionitis? As all the situations in Gina knows, to have a previous event is a risk factor for the next one. So the first risk factor is to have another pregnancy with premature ruptures of membrane. Genital tract infection, urinary tract infection, and for example STIs, they're also risk factor. Antepartum bleeding, as the last class was about antepartum bleeding, Sebastian made it, so we can check the note. But abruptio placenta or all the antepartum bleedings are risk factor. Okay, cigarette smoking by the inflammation, trauma, intrauterine device, also both of them produce mechanical inflammation, cervical mechanical stress, and inflammation, cervical incompetence. We will not talk about cervical incompetence in this class, okay? And all the situations that produce abdominal distension, it is also a risk factor for PPROM, okay? For example, polyhydramnios, gemellar pregnancy, and macrosomy. So, what about the clinical findings? So, we are in the labor ward, I don't know, 3 a.m., a Friday, tired. So, which are the suspect sentences that the patients will tell us, and we have to suspect about PROM. So the most commonly is sudden gush of clear or pale yellow fluid from the vagina, soaked through clothes. That's the typical, no? The pregnant woman who came saying the water breaking. I broke my water. I broke my water bags. So, but that's very easy to diagnose because we have the diagnosis made with this story. But there are some cases that the story is not so clear, and we have to be focused because sometimes the gush is just a few gush. It's very little, so leaking only small amounts of fluid, either continuously or intermittent. And more difficult than this situation is just the sensation of abnormal wetness of the vagina or perineum. So probably those women who just have a sensation and they have a PROM, they will delay their going to their hospital. They will delay the consultation. So that's very important for us to prevent saying that this is also an alarm sign. Okay, just the sensation, because we have to rule out the ruptures of membranes. Okay, what about the physical examination? So the most important thing that if the patient is not with pain and we don't suspect in active phase of labor, we have to make a sterile speculum. That's the most important thing, and the first thing. Well, after taking the vitals, etc., of course, but in the examination, in the genital examination, we have to do sterile speculum. Okay. What we're going to see? we have a few options to see and to find in a speculum. The first one is the direct observation of amniotic fluid leaking from the cervical os, and also a pooling in the posterior fornix. That is pathognomonic of ruptures of membranes. We don't have to. We have the diagnosis made, done. Okay. What if we don't see clear, or we have some doubts? We have some maneuvers that we will to see it clearly. For example, to make the patient push, to make her doing Valsalva, or to cough, and that will provoke the leakage of amniotic fluid. Okay. Also, in the speculum, it's not our main goal, but we will see the cervical modifications. We can see if we will see the membranes, if it's very dilated, or we can see, well, everything that we can see in the speculum. Okay. Here I put a vaginal examination in a gynecological patient, not in an obstetric patient, but just for. Why do you think that I put this image? We have to make a VE, or we don't have to make a VE? No. Very good. So the digital examination, or the VE, the vaginal examination, should be avoided. It's forbidden because it increases the risk of intrauterine infection. Okay? So this is not just in a context of ruptures of membrane. This is always. So that's the importance that we should maintain the sterility of the gloves. We have to clean the genital area before to do a VE, etc. Okay? Because we prevent intrauterine infection. We will see after that Corioamnionitis. We will see many definitions, and we will see if they are the same, if there are some difference, etc. Okay? So we have seen the story and the physical examination. What is after? The laboratory request and the ultrasonography, or the ultrasounds. Okay? So if we have some doubts in the speculum or in the story, we should go to the ultrasound. And what is going to show us the ultrasound? It's going to show oligohydroamnios. Okay? You know what it is? Perfect. So it's defined, just a few words about it, like maximum vertical pocket, or MVP, of amniotic fluid less or under than 2 centimeters. Or another definition is the amniotic fluid index, or the AFI, less or equal than 5 centimeters. Perfect, clear? And also, of course, the ultrasound will provide us the information about the fetal status. Okay? So, the laboratory, why it is so important? Because in a stable patient with PROM, with reliable ruptures of membranes, the exams, the hematology and chemistry tests should be normal. But in case that there are some infection or some subclinical infection, it will change the laboratory test. So that's why it's very important to always remember this, okay? We will see which one they are important in these cases, okay? So what about the physical examination? Sorry, about the diagnosis. First, we have the physical examination, okay? We can see through the speculum we can see through the speculum, we can see the pooling or the gush of fluid, and it's going to be very easy. We have the diagnosis, okay? If we have some doubts, we have the ultrasound that will show us the oligohydroamnios. But what if we don't understand, we don't have clear the diagnosis? There are some few tests, amniotic fluid tests, that will confirm the diagnosis of PROM. Yes? So I'm going to see very fast a few of them, and sadly here in the Valladolid hospital we don't have any of these tests. Okay? So in case that we have doubts, we should maybe refer to the Kenyatta or something like that. Okay? But just in a few cases we will need to see it, to use it, because we have first the physical examination, then the ultrasound, and then if we have doubt, we have to use the specific test. Okay? So I think that you will not see because it's very little the letter, sorry. But here we have commercial tests. There are packs, kits with some sticks and with some laboratory tests. where you can search for some proteins of the amniotic fluid. The most known is amnisure. Have you heard about it? Amnisure? So the amnisure will search through this process a protein called placental alpha microglobulin 1 protein assay. Don't worry about the name, doesn't matter. Okay? But it's very easy to do it. It takes no more than 15 minutes and you can have the diagnosis. Okay? But the problem is that it's not much available and not in the bagarios. Okay? There are another that you search the insulin-like growth factor binding protein 1. Don't worry again, but it is worse than the amnesia. Okay? These are commercial tests, very easy, but the problem is the availability. And we have another test that are more common and more available than the last one. That is the nitrosin paper test and the fern test. You have heard about it? Perfect. So the nitrosin test, we search the change of the pH, because the normal pH of the vagina is yes, around
4.
Around 4, exactly. It's from 3.8 to 5.2, an average, of course. So, if the baby in the womb lives in this acid environment, will die very fast. So the amniotic fluid, it is like neutral. It's more basic than the vagina. It's around 7 and 7.3. So if you, with a dipstick pH, you can do it like the urinary dipstick is the same. And you will find the pH, and if the pH is around 7 and 7.3, probably you are in front in case of PROM. And the second one is to see the secretion in the microscope. If you see a ferning pattern, that's why the name is fern. Ferning pattern is like, I will not know how to explain it in English, but it's like fern. Yes? So, before to continue, a fast quiz. Which is the capital of my country, Chile? This is the capital, and this is the Los Andes chain mountain. These are the tallest building in all South America. So which is the capital, you know?
Good question.
Yes? You don't know? Oh, disappointing. So it's Santiago de Chile. Okay? Okay, we have seen now a few aspects of PROM. Now we're going to the management. Okay? So, as I told you in the beginning, the management is very controversial. It's controversial because it's difficult to have an accurate diagnosis. It's difficult to know when do we have to have expectant management versus to intervention. When do we have to use tocolysis, the duration and administration and which one of the antibiotic prophylaxis we have to use, the timing, the methods of diagnosis, the timing of delivery, etc. Okay? Oh, sorry. I have a few problems. So, now, Here are the general principles about the management. Okay? So the first one, this is theory. The first one is to have always remember the full story, the full physical examination, to request the laboratory and the ultrasound, specific tests just in cases, or to refer in cases that we don't have and we still have doubts. This will allow us to have an accurate diagnosis. Then it is very important to always have a teamwork, to work with the nurses, with the MOs, with the clinical officer, etc., with all the team. Okay? And very, very, very important to continuous monitorization. Because at the moment of the diagnosis, maybe we will need to have an expectant management. But one day after, or tomorrow, or 1 week after, maybe we will need to interrupt. So that is the importance of the continuous monitorization, that the treatment is very variable. Okay? And we will divide the management of the PROM in these two cases. We put this limit because of the viability of the fetus, okay? So for a stable patient with PPROM, stable patient, over 23 to 34 and over 34 to 37 weeks, okay? Before this, it is almost the same, but without using corticoids because we don't want to produce the maturity line because it's not needed, okay? So first we're going to start over 34 weeks and under 37, okay? Because this is preterm pre-labor, PPROM, okay? So the management, theoretically, is the delivery. We have to interrupt, okay? The way of delivery, which is the most common way of delivery here? Is the spontaneous vaginal disease. The cesarean, we just use it in cases that the cesarean is the standard indications, but we need to prefer the vaginal delivery, okay? In case that we have, for example, an infection and we open and we make a cesarean section, it will increase the risk of have yes?
Septic discharge?
Yes, a sepsis and intrauterine infection, okay? So the way of delivery is the normal delivery. Cesarean, just in case that we need cesarean for another indication, for the standard indication, okay? Remember that we are in cases of stable patients. If we are in cases of Corioamnionitis, it will change immediately, okay? What if we don't have a safe gestational age? And this is the problem very common here in Bagadri. Or we have, for example, an ultrasound, but a late ultrasound, after 28 weeks. So we will have a difference for 3 weeks of the exactly gestational age. So in those cases, we have to be very careful with this, because this is going to be very common here in Bagadri. We have to have expectant management until 36 to 37 weeks. Because those 3 weeks that we are uncertainly about the gestational age will give us a safe period of time where we can interrupt the delivery, so during the pregnancy. Okay? Clear? Any doubt? Perfect. So what about under 34 and over 23? Here we have to add something. Okay? We have to add first. We have to. The main important thing and concept is to have expectant management. Okay? With corticosteroids, with prophylactic antibiotics, and with hospitalization in all the period of time. The corticoids, as we have seen in other classes, will reduce the mortality, the morbidity of the prematurity if preterm delivery occurs. And the prophylactic antibiotics we recommend, and the guides recommend, ampicillin and erythromycin. The erythromycin is not just an antibiotic that will be useful for the for the bacteria. It is also increase the latency, the latent period from the start of the ruptures of membranes to the delivery. It will increase this period. So that's we want. That's what we want. We want to increase that period. We want to delay the delivery as much as better. Okay? So, what about the tocolysis? The tocolysis are indicated or not? The answer is yes, but there are many situations that contraindicate the use of tocolysis. We indicate the tocolysis for the delayed delivery at least 48 hours, but not just because it will have a benefit for itself. It will allow the corticoids to make this function. Okay? So that's the most important. We give tocolysis for the use of corticoids, for corticosteroids. But there are many contraindications that we will see that are the same indications of interrupt the delivery, that are advanced labor, over 4 centimeters of dilation, Corioamnionitis, or just to have the ruptures of membranes after 48 hours. This is very important because it is like probably is colonized and we can't give tocolysis. Okay? The non-reassurance fetal status, the abruption placenta, and the risk of cord prolapse as malpresentation. We have seen that one risk of cord prolapse is the malpresentation, as, for example, also in this situation, the cervix dilated. It is also a risk factor. Okay? So, the next slide is about when do we have to interrupt? Oh, sorry.
If you give a patient who is dilated 4 centimeters and you give a tocolysis, what is the main thing that you fear?
Hello, how are you? Yes.
Thank you.
So I will answer your question immediately, okay? Just for contextualize the new ones, we are in the seminar of Corioamnionitis and ruptures of membranes, okay? Now we are ending the the ruptures of membrane part, okay? So answering your question is very good question, and for everyone to hear is why is our main fear to give tocolysis after 4 centimeters dilated in a patient with ruptures of membrane. True?
Yeah.
So we give tocolysis. Which is the main goal for give tocolysis? To delay the delivery for the using of corticosteroids. But in these cases, when the second phase of labor it's already the second phase of labor, the tocolysis will not act and we will not have the delay of contraction the delay of period that we will need for the corticosteroids. Okay? Yes, understood? If you want to add something.
For example, tocolysis that commonly used here is nifedipine, oral nifedipine, you know?
Oral nifedipine.
The effect of the nifedipine is like 2 hours, between 1 hour and 2 hours. Start the effect. If the mother also had eat before, is the full stomach, it will last more than that. And if the mother is 7 centimeters, or 4 centimeters, for the delivery it's like only 1 centimeter per hour, so it will be not too much. So the effect of the tocolysis is not so good in the active phase of labor. It's very good in the latent phase, or when you have a threaten of labor, like symptoms of labor.
Exactly.
Symptoms of preterm labor, but not after that.
Clear? Perfect. So when do we have to interrupt, or when is the correct time of delivery? So we will have expected management as much time that we can, but we have to continue monitoring the patient, because if we are in case of an intrauterine infection that we will see in the next part of the class, the criteria for diagnose an intrauterine infection, or we have a ruptured placenta, a non-reassuring fetal status, or high risk of cord prolapse that we saw that it was the contraindication of tocolysis. In those cases, we have to interrupt immediately. Okay? Perfect. So another fast quiz. Which is the most recommendable antibiotic prophylaxis for a stable patient with P-PROM? Ampicillin, gentamicin, ampicillin, erythromycin, ceftriaxone, penicillin, nitrofurantoin, and clindamycin. What do you think about it? The new ones. You weren't here in that part, but
I hope that is erythromycin.
B? You say B?
Yeah, if that erythromycin is the same as erythromycin. So I go with B.
B? All agree?
I go with B.
Perfect. It is B. Remember that ampicillin and erythromycin will prevent it is antibiotic prophylaxis, but it also, the erythromycin will increase the latent period from the ruptures of membranes to the delivery. So that's what we want. We want to earn time, okay? Now we're going to the next topic, that is Corioamnionitis. Okay, we will hear about Corioamnionitis, intrauterine infection, or triple I. Okay, triple I is intrauterine inflammation or infection. Okay, we will hear those and we will use it here as synonyms. Okay, and IAEI, sorry, it is the same, it's an abbreviation. Okay, and triple I. So we will use it as synonyms. Okay. Then, what is the definition of Corioamnionitis? It's the acute inflammation of the membranes and chorion of the placenta, and has the potentially serious adverse, like maternal, fetal, or perinatal effects. Okay? The incidence, we saw it in the beginning of the presentation, is around 1 to 4 of all the deliveries. Okay? So we will see many here in Baradi Hospital, because we attend many pregnant women daily. Okay. What about the pathogenesis? And just a summary again, because there are many diagrams, theories, etc. about this pathogenesis. But the most common pathway for the microbes, for the bacteria to go to the chorion is to going up through the cervix, through the vagina. Okay, and the most common is in a patient with the ruptures of membrane. Okay, that's the most common. There are other pathways, but non-common. That is the maternal bacteremia, and usually is the Listeria monocytogenes. Infection is through the bacteremia of the mother, and also the Staphylococcus aureus. For example, when we have dermatological infection, okay, skin infection, and also from contamination of the amniotic cavity as a result of an invasive procedure. Of course, that if we do amniocentesis, we will have more risk of Corioamnionitis. Okay, but the most common, and we have to remember always that the most common pathway is ascension of the flora from the vagina, okay, and from the cervix. A little about the microbiology. I don't want to know all the names of the bacteria. It doesn't matter. We can search in the internet. But the most important concept for this is that it's polymicrobial. It's more than 70% of the cultures of amniotic fluid, we will find more than 2 microbes. Okay, so that's the most important concept. The non-polymicrobial are usual in the hematological transfusion, in the Listeria, Staphylococcus, in the bacteremias of the mother. Okay, we will find in that situation we will find monomicrobial. Okay, so the common isolated bacteria, the most common, just for you to know, is the genital mycoplasmas, like ureoplasma and mycoplasma, and we will find anaerobius, Terrigram-negative bacilli, etc., etc. It doesn't matter. Okay, so what about the risk factor to have Corioamnionitis? As we said, the most common pathogenesis is the absence of the flora of the vagina and the cervix to the colon. Okay, so we will need a long rupture membrane to give the bacteria time to go up, and also long labor. Other risk factors, so the main important risk factor are the long labor and long rupture membranes. Other risk factors, we will find the multiple vaginal examination, and we have said for the others who came recently that that's the importance to always do a BE very sterile and to clean the genital area before, etc. The multiple BE, the cervical insufficiency, the nulliparity, STIs, as also urinary tract infections, alcohol, tobacco, because this is a risk factor for PROM, previous